Another place that I tend to intubate people is in the ICU. And the ICU can have sicker patients, obviously, and there's quite a bit more complications that can happen with intubation. So we take those procedures very seriously. In fact, when we do intubations in the ICU, up to 40% of our patients, when they get intubated, can have cardiopulmonary complications that happen in that peri-intubation period. Now, the key takeaway is that most of the complications happen in the cardiac system or the pulmonary system. And so optimizing your patient as best as possible before you intubate them, and then setting yourself up for success during the intubation is usually going to avoid any of those complications. Starting with the pulmonary complications that can happen, most of them come with hypercarbia or increased CO2 or hypoxia, which means not enough oxygen. Now, if you're intubating people, most of the time they're having some sort of respiratory distress. And so these patients are probably already on an increased amount of oxygen or ventilatory support. Many times when I'm intubating patients, they'll be on BiPAP, which is a non-invasive way to provide positive pressure, or they'll be on a high flow nasal cannula, which gives them additional oxygenation. Now, before we put patients to sleep in the operating room, we tend to pre-oxygenate them with 100% oxygen. We can continue doing the same technique in the ICU by using BiPAP or high flow nasal cannula, even up until the point where we are getting ready to intubate them, which helps both ventilate the patient and oxygenate the patient as we're inducing anesthesia. Studies have shown that just keeping a high flow nasal cannula on the patient during laryngoscopy and during the whole intubation period helps reduce hypoxia or desaturation during that process. The thing that helps with first time intubation success is using a video laryngoscope. So oftentimes I'll have a McGrath or a glide scope available with me, but I also have a direct laryngoscopy blade also available just in case there's any equipment failure or if I have any GI bleeding, which can really make it hard to see once you get blood on your camera. And so those are the scenarios where then I would reach for either a milliblade or a Mac blade and then do direct laryngoscopy. In terms of the cardiac complications that usually happen, usually it's hypotension that requires a new pressor to be started. And for patients who are critically ill, a lot of times they don't have much reserve in terms of their sympathetic storm. And so once you induce anesthesia or sedation, they lose that sympathetic drive and all of their catecholamines basically fall to the ground and they're relying on exogenous or additional pressors to keep their blood pressure up. One thing that you can do prior to inducing sedation is do a point of care ultrasound to see how full their heart is with fluid or if they could benefit from a bolus of IV fluids prior. The other thing you can do is make sure that you have pressors in the room so that if they do get hypotensive, you can start that medication right away. A lot of times I will have a stick of phenylephrine with me or a syringe of phenylephrine so that I can give small boluses with my induction. The other thing you can do is just use a correct induction agent for your patient to help prevent hypotension. So rarely do I ever use propofol in the ICU, mainly because it's a direct negative inotrope for patients' cardiac function, so it reduces their contractility. And usually the vasodilation that patients get is something that they cannot tolerate when they're in the ICU. So my usual drug of choice to put people to sleep is going to be etomidate. Best ways to prevent cardiopulmonary complications when you're intubating people in the ICU is to make sure that you have them well pre-oxygenated, continue any non-invasive positive pressure ventilation up until the point when you're ready to intubate them, make sure you have pressors in the room, assess their volume status prior to induction, and always use the equipment that's going to help you with the first pass success rate.